I'm not sure if this is easier or harder than following Sir Michael in speaking, so I'm not sure how this is going. Anyway, it's easy for me because basically there are actually only two of us. There's myself and Steve, and I'm effectively Steve's warm-up man. So you're just going to get 10 minutes of me, and then I'll hand over. So I'm going to say a little bit about what the background and rationale for this is, and I'll keep filling in while we get the slides up. Yeah, perfect, perfect. Essentially, well, firstly, can I say thank you very much to Alice for inviting us to this event. And secondly, a huge thanks to Rachel and Louisa for the public health team for the support they've shown in our work to date so far. From my own perspective, perfect. I've been working in the addictions field for about 35 years now, so I am indeed every bit as old as I look. But I guess my primary warrant for doing this is I've collected just over 4,000 recovery stories. So one of the big things for us to start with is to say recovery is possible. People do recover. Change does happen. And I'm going to give you just a little bit of background and evidence about how it happens and what it looks like. So let me start by the fundamental summary of recovery science, which you can frame in two basic ways. One, what helps people recover? Jobs, friends, and houses. Or you can reframe that as somewhere to live, someone to love, something to do. And all of the things we will talk about, the golden thread of addiction recovery is around those things. A place that provides you with psychological safety, a sense of belonging and identity, and some kind of meaningful activities. I do a lot of work in prisons as well, and exactly the same is true for desistance from offending. The same fundamental principles. And it's also, I guess, important to say, look, what do we know about recovery? It's not overnight. I did my training at the South London and Maudsley NHS Trust, big teaching hospital in South London, and we still bought into that notion of miracle cures. If we could just get detox better, if we could just get rehab better, people would be fine. But it doesn't work like that. We know that recovery is typically a 5-year journey post-detox. In the first year after somebody detoxes from alcohol or opiates, the likelihood they'll relapse is between 50 and 70%. If they manage 5 years of continuous sobriety, that drops to about 14% and doesn't really drop any lower than that. So effectively, what is the point of having a recovery movement? The point of having a recovery movement is to get as many people as possible to that point. Now, you'll notice there's also another statistic up here, which is, contrary to what lots and lots of people think, of all the people who have a lifetime substance use disorder, 58% of them will achieve 5 years of continuous sobriety. So just under 2/3. So it's not an inevitable relapsing, chronic relapsing condition. But I'm going to take a leaf out of Sir Michael's book because we know that if you look at the recovery rates for those who you might describe as the least deprived, airline pilots, lawyers, and doctors, their recovery rates from alcohol and opiates are all in excess of 90%. 90, 9 out of 10 people recover. So what that means is, if we can make the conditions right for recovery, we shouldn't accept 58%, which anyway means 42% of people die addicted. We need to do better than that. And the whole point of what we're talking about is, how do we create the conditions that maximize the likelihood that people will recover? And I tend to put this slide up quite often from one of my earliest recovery studies. I studied what helped people recover in Glasgow and Birmingham. We took 200 people who were in recovery from heroin addiction and alcohol addiction, and we refer to this study as the Goya study after the Spanish painter Francisco Goya. And what did we find were the biggest predictors of who recovers? Two things. The more time you spend with other people in recovery, and the more meaningful activities you engage in. So of all the measures we took, the simple basic measure of how many hours in the last week you'd engaged in childcare, volunteering, education, training, employment, the better you did. Why would we call a study like this after a Spanish painter? Well, Goya is an incredibly complex scientific term that stands for get off your arse. The more you do, the better you do. The more active people are, creating the conditions for recovery is a self-driven thing. It requires motivation. But we as communities can create the conditions that allow that to happen. And it's a fundamental mindset change. And I don't know whether the same is true for you. I'm just checking there's no children left because I am about to start swearing. One of the things that in my world that is fundamentally different, people now talk about treatment and recovery services, but that is generally complicated because a treatment service does completely different things from a recovery service. A treatment service operates on an expert-patient relationship. A recovery service relies on much more of a parity of esteem, parity of equity, and it switches from deficit-based questions to strength-based questions. About 200 years ago, I used to run a brief assessment clinic for heroin addicts in the Stockwell Project in Brixton in South London. Someone I'd never met before would come in, and I'd have about 25 minutes to half an hour to run through a big, long questionnaire about, tell me about your physical health problems, your mental health problems, your relationship problems, your crime problems, your drug problems, your alcohol problems. I felt miserable at the end of it. God knows what they felt like afterwards. And in addition to which, it's a clear power disparity. So as a very professional psychologist, about the 6th or 7th question I would ask somebody was, how many people have you had unprotected sex with in the last month? Which, you know, if any of you are going home in the bus later, don't ask a stranger you meet that question first off. You might get a slap in the mouth. And crucially, if the client were to say to me, why, how many people have you had unprotected sex with in the last month? In a highly professional manner, I would say, just answer the fucking question. It's a power disparity. It's fundamentally wrong. We never asked, what are you good at? What do you like? What can you do? And it's fundamental we flip that model. And a lot of what Steve is going to talk about is how do you identify assets, individual, community, collective, and societal, and then mobilize them to create the conditions for change. The location recovery occurs is not a specialist clinic. We're not capable of sprinkling magic dust on people's heads and making them better. And crucially, the fundamental way people recover is peer-to-peer. We talk about recovery contagion. The fundamental way it happens is, I want what you've got, and I'll do what you do to have what you have. If that's the model, we need as many visible, attractive, engaging, accessible groups and individuals in that recovery process to make people think recovery is available and recovery is possible. So peer-based is the primary mechanism of action. I'm not going to talk about the boring science bit at the end. This is an outside-in model. We cannot either medicate or therapize people into addiction recovery. Fundamentally, people recover by building up the resources, which we call recovery capital. But contrary to a clinical model, how we do that is by creating the conditions, making recovery accessible and visible. We build community capital that allows people to develop new social networks and new connections that allows then for that growth in personal factors that takes place over time. And again, to go back to something that was said earlier by Sir Michael, the underlying model we use in both mental health recovery and addictions recovery is called CHIME. And it's nearly in the right order. So if you want to know, does a program help somebody recover? We would generally cheat and use this acronym to say, does it enable these 5 conditions to happen? It fundamentally starts with human connection. Of the 4,000 recovery stories I've collected, the only thing they all have in common is nobody does it alone. Lots of people have a cunning plan of, I'm going to lock myself away in a flat, fill it with pot noodles and DVDs. Actually, I'm 20 years out of date with that particular illusion. Fill it up with stuff and never go out again. But it doesn't work. Every single one of those recovery stories involves somebody or some group making a fundamental connection that creates a radius of trust, and generally a peer-based radius of trust, which generates hope. Hope that if you can do it, I can do it. And the hope motivates engagement in meaningful activities, which affords positive identity change and a sense of empowerment. Chime is great. Chimay, which would be the right order, doesn't sound quite so good. But Chimay is kind of the right way around. And we now have a science of recovery. We know that what it takes for people to recover is effectively to have the access to the internal and external resources that support people on that recovery journey. And essentially, what we are doing here is banking on a slightly different theory of how this works. This quote is from my own mentor, Professor John Braithwaite from the Australian National University. Social capital, human capital, recovery capital, and restorative capital, unlike financial capital, in that they are not depleted through use. When you spend your money from the bank, as we sadly all know, you deplete your resources. But when you use recovery capital, when you trust someone, you do not deplete trust. It is generative. And the whole point of a recovery contagion is it leaks. Hope and connection spreads into communities. And these are the conditions under which we are creating our Inclusive Recovery Cities model. The Inclusive Recovery Cities model is predicated on the idea that if you can improve the level of community connection, the access to resources in communities, therefore, you increase the likelihood of people developing a sense of positive belonging and then developing those internal characteristics: resilience, self-esteem, self-efficacy, coping and communication skills that are at the heart of recovery success. And going back 15 years, we combined our data from Glasgow and Birmingham with data from a US researcher called Alexandra Lode from New York. And we basically come up with these three slices or buckets. You want to build those personal resources in people, help them build them, but you do it through giving people access to community resources that creates the opportunities for moving away from stigmatized, excluded, and marginalized groups into pro-social activities. Every one of the large-scale, long-term outcome studies for addiction recovery reaches the same simple conclusion. The single biggest predictor of recovery is moving from social networks supportive of substance use to social networks supportive of recovery. It's the group norms, beliefs, and values that shape the recovery journey. And so for us, the whole idea of Inclusive Recovery Cities in Newcastle is, how do you get people from stigmatized, marginalized, excluded groups into things that give their life a purpose, and groups and identities that open doors for them? This, remarkably, given that the sun is out, is Glasgow. This was the second UK recovery walk. Why do we have these things? Well, the point of visible acts of celebration of recovery are to challenge stigma, negative attitudes that nobody gets better, to celebrate the achievement of recovery, to create connections among people in recovery, but also to create opportunities for volunteering and citizenship, and to contribute to the civic calendar. What we're doing here in Newcastle and a number of other cities is creating those conditions to bring people together with public-facing events to celebrate recovery and create recovery as a movement. Our Inclusive Recovery Cities is a number of requirements that starts with those four things. I want to give Steve more time, so I'm not going to go through this big list, but essentially the aim is to create attractive visibility for recovery, to allow people to access general public to challenge stigmatizing attitudes, people not yet ready for recovery to make them believe recovery is available and accessible, for people in recovery to create bonding social capital. And the underlying theory for this is all about social capital. We now have 10 recovery cities in the UK. And what Steve is going to talk to you about is partly about, we had spent yesterday training community connectors. This is not something about what might happen. This is happening here in Newcastle already. And we've already been in this room 6 months ago, maybe 6 months ago, where we launched Inclusive Recovery Cities in Newcastle as a movement of hope. a social movement for momentum and hope to initiate change. And essentially for us, I'm going to just go back briefly, we now have 32 inclusive recovery cities. In the last couple of months, the two newest cities we have are Tampa Bay in Florida and Cape Town in South Africa. This is an international, we have 15 cities across the Balkan region of Serbia, Bosnia, Montenegro, and Croatia. And the whole point of this is to create multi-layered connections, to challenge exclusion and stigma, to generate opportunity, and not just to help people in recovery, but predicated on a ripple effect, that if you help people in recovery, it is both an act of intervention, but it's also an act of prevention. It's a form of breaking the intergenerational cycle of drug use and crime. It's also a mechanism for creating hope, visibility, and diversion much, much earlier in a recovery journey. We typically think of the average, well, the science says the average length of an addiction career is 28 years, from the first time of active substance use to 5 years of continuous sobriety. What we want to do is to create the conditions and change the conditions that improves that likelihood and that enables the people to start that journey earlier, to be aware of recovery and have access to the resources for recovery. And now I'm going to hand over to Steve, who will tell you where we are up to and what we have achieved in Newcastle to date. So thank you.